Hi, welcome to the medical student whom join us in this virtual session of the clinical skill teaching. Our subject today is the breath sounds, or sometimes called pulmonary sounds, or chest and the auscultation of the chest, or auscultation of the lung. Today is the normal breathing sound. Before discussion the breathing sound, you have to know some point about anatomy. This is airway passages, large airway passage like trachea, and this right main, left main, and this is the large airway passage. This is a medium-sized airway passages, while the small bronchioles is the small airway passages. Other part important is that it's a large airway, medium and small airway. The terminal is that the respiratory bronchioles, from the bronchiole there and alveoli. So passage of the air in the lung, for large, small, medium, and in alveoli it's produce what called of pulmonary sound, or the breathing sound, which can hear sometimes. This is a normal, and there is an abnormal sound. Here in the chest, by the aid of a stethoscope, you have to know that the part of the stethoscope is the earpiece and this tube, and tube, sometimes in a stethoscope 2 tubes or sometimes 1. And this is an important chest piece, the piece in which to be auscultate the chest. There is a pail for low pitch sound and diaphragm, high pitch sound. The pail, if it's applied firmly on the chest, it's act like the diaphragm. And the area in which auscultate from the backs, there is 4 areas, and the upper left, upper right, upper left, and the middle and the lower. And this is 4 area of auscultation. During auscultation, from upper left, upper right, middle left, middle right, and the lower zone here, near the axilla, all the 4th area below the scapula. Really to auscultate from the right to the left, and in this way. From this, auscultate another to compare. Then downward to the middle right and go to the left. Then downward to the left and go to the right. In this way, better and consuming the times for auscultation. Anteriorly have 5, sometimes 6 areas of auscultation. On the clavicle, auscultate there and transmit to the left side. Down to this and to the right side. Down from right to the left side. In axilla, sometimes 1 area and sometimes 2 areas for auscultation. And in this way, this is from the clavicle there, and then the down and to this clavicle, and just down and to the other area. Or could be from this and auscultate this area. Return back to the right side and left, and return back the right and to the left. Or from this area, from the right to the left, down in the left, auscultate this area, compare with this area, down and compare this area, and so on. So we see the auscultatory area and the anatomy, simple anatomy and applied anatomy of the airway passages. This sound really produced in the lung, or breath sound, or respiratory sound, or lung sounds, refer to the specific sound generated by movement of air through the respiratory system passages. These may be easily audible or identified. Maybe with the bare ear we can hear it. Or sometimes we need a stethoscope, auscultation of the respiratory system through the lung field with a stethoscope. These include the sound, normal breath sounds such as vesicular and bronchial or broncho-vesicular, and the adventitious this is wrong, right, this is vesicular, V-I-S-E, vesicular breathing sound, and adventitious or added sound or abnormal sound such as rowels, wheeze, pleural friction, and stridor. We will discuss all these sounds, a mechanism, and when to auscultate and that the clinical significance. Vesicular, this is the correct writing, vesicular breath sounds. These are the most common sound, auscultated breath sound, normally heard over the most of the lung surface, anteriorly and posteriorly. For every sound, you have to know how to hear it. In the chest piece, use a diaphragm. Some clinicians use the PAL. Follow that the instructions on your textbooks. Use a diaphragm for all that the respiratory auscultation. Position in a chest wall, either anterior or posterior. In a sitting position, sometimes when the patient lying, preferably in a sitting position. The vesicular breath sounds, these are the most commonly auscultated breath sounds, normally over most of lung surface. What the characteristic of this sound are soft and low pitch, rustling quality during the inspiration and are even softer during expirations. Like يعني تشبه صوت الحفيف أو الخشخشة البسيطة. Have inspiratory expiratory ratios 3:1. Prolonged inspiration. Expiration is that the 1/3 of time of that the inspiration. Can be heard over most of areas of the lung. Sound intensity can be higher when the stethoscope is positioned near to the base and posterior of the lung. Causes of this is normally found, and if causes of diminished breath sound, causes of generalized reduction in intensity of the breath sound, I mean vesicular breath sounds, obesity, hyperinflation of the lung like chronic obstructive airway disease, hypoventilation in a life-threatening asthma, what's called silent chest, so that the causes of localized reduction in breath sound, it's not generalized, not all over the chest bilaterally. Bronchial occlusion, preventing air entry into the lobe, collapsed lung or lobe, pleural effusion or pneumothorax, and the unilateral paralysis of diaphragm or intercostal muscle. Before we move to the other breathing sound, you can hear that this is the vesicular breathing sound. Now come to the bronchial breath sound. Bronchial breath sounds are hollow tubular sounds that are lower pitch. They can be auscultated over the trachea normally or below the right clavicle, especially in children, where they are considered normal. If heard in the chest, they are abnormal and suggest. If we hear it, normally present in the trachea, but when the air transmitted, it's attenuated by the lung tissue and alveoli, so we can't hear it on the surface of the chest. But if we hear it, put in your mind there is either a consolidation or fibrosis. A technique, use a diaphragm and in the chest wall, anterior or posterior, and in the sitting position is preferably. What the characteristics of a bronchial breath sound? Distinct pause in a sound between inspiration and expiration. There is a pause, gap between them. Inspiratory and expiratory is a reverse. In the vesicular breathing sound, 3/1. Now it's reverse, 1/3. It's more prolonged in the expiration. Harsh and poor in nature. What the mechanism of produce breathing sound? I mean bronchial breath sound. The sound of bronchial breath are generated by turbulence of airflow in large airways. Our similar sound can be heard in healthy patients by listening over the trachea. In healthy patients, however, these sounds are not conducted to the chest wall since they are attenuated by air-filled alveoli and lung parenchyma. In the presence of consolidation or fibrosis, as we said, however, the sound of the air flow in the bronchi is conducted more effectively to the chest wall by this consolidation of fibrosis, and the bronchial rather than vesicular breath sound are heard. Causes of bronchial breath sound: you have to know firstly consolidation such as lobar pneumonia, localized in pulmonary fibrosis, and the lung cavities like pulmonary tuberculosis and pleural effusion at the level above the effusions. Note that at the effusion, as we said, the effusion, there is no sound will be heard on the in the pleural effusions. The bronchial breath sound, you can hear this is a tubular, harsh, there is a gap, expiration more prolonged. Another normal sound is the combination of the bronchial and vesicular, what called the broncho-vesicular breathing sound. These are normal sound in the mid-chest area or in the posterior chest between the scapula, the better place to hear it. Also use a diaphragm by stethoscope in a chest wall, especially posteriorly between the scapulae, and the maneuver in a sitting positions. Its inspiration to expiration periods are equal. As we said, inspiration in the vesicular 3/1, while is the reverse in the bronchial. Here it's equal. Mechanism, they reflect a mixture of pitch of bronchial breath sound here near the trachea and alveoli with the vesicular breathing sound that hear it. So we can hear the broncho-vesicular breathing sound. Next lecture will we discuss that the adventitious or added sound or abnormal respiratory sounds found in the disease. See you soon.